today, start and finish, is part 2, positioning of the lower limb, okay? Next time we'll do 5B, and I'm thinking we might could finish the whole thing in one day, okay? But anyway, so we're going to do positioning of the lower limb today. Now, I'm not out to make you into a positioner, okay? That's not what the goal of this is. The goal of this is when you look at images, you can understand what you're looking at because you have an idea of how they're positioned. Okay? So, so again, I'm not expecting you to know how to position perfectly or anything like that. Okay? Just the general idea so you know what you're looking at. Okay. So let's talk about some technical and positioning considerations that we have to think about anytime that we take an x-ray, especially, or when we're looking at an x-ray, especially when we're doing lower extremities, okay? So the first thing is we have to have an SID of 40 inches. What does SID stand for? Do you guys remember? Source to image distance. Why are you asking me? You knew it. Yes, you're correct. And that's the middle of the X-ray tube to the image receptor. That's the SID, source to image receptor distance. Okay. When we do stuff on the table, that's typically going to be 40 inches for us. That's standardized. And the reason why it's standardized is because our technique will change when the distance changes. And we want to make sure that it's standard so it doesn't change, okay? Okay, now the next thing on this list is gonadal shielding. I thought I had told you guys before how the rules on shielding have changed, but my first 2 classes told me no, they didn't know. So at the end of last semester, we found out that the rules changed for shielding. The rules changed to no shielding. Okay, now we've been shielding for over 90 years. Okay, I've been shielding for more than that. So and I've been teaching about shielding. I mean, I force it onto you guys. And now we're told no shielding. It hurts my heart to have to tell you guys no shielding. It does, because I still believe in it. But their reasoning is that the machines are better, they require less radiation, the collimators are better, they're very good, they're very exact. So, so shielding does no good. Okay. So all the studies that had been done 50 years ago. So they decided it was time for a change. They did new studies and decided that you don't need to shield. Okay. So having said that and seeing this on here, then I'm going to do something drastic. Stab it. No shielding. Okay. All right. 4-sided collimation, because pretty much everything is digital. When you collimate now, the image receptors are going to read what's outside the collimation. And when it does that, it will include it in its decision on how to change your technique. And we call this rescaling the image, okay? So it will change your technique according to something that it reads outside of your collimator, and you don't want that to happen, okay? So if you're only 3-sided because one side is off of the image receptor, okay, then your image is going to be way too dark. Okay, so it has to be able to notice all 4 sides. Okay, Also, you need to take into consideration that you're doing the correct part, that you got correct CR alignment, that the part is parallel to the image receptor and the CR is perpendicular to the part and the image receptor. Okay. Do you remember what CR is? Central ray. Okay. And you have to have the proper anatomic side marker. So we're talking about the letter markers, okay, that you have a right for the right side, a left, or a left for the left side, okay? And not only that, but it needs to be placed inside the collimation. Before, we used to have a lot of fog or densities outside the collimation. And if you had a letter marker out there, there would be enough densities to where you would see the letter marker, even though it's outside the collimation. We don't have that so much anymore. So your letter marker must be inside the collimator, inside the collimated area, okay? Let's go back to this correct part. You also have to make sure you have the correct patient. I've seen many people take many x-rays on the wrong patient. And don't think that the patient knows, okay? That patient may be there for you to do an abdomen and you do an ankle and they don't say anything. You know, they assume you know everything and maybe you'll get a picture of their abdomen through their ankle. Who knows what they're thinking? Okay, but lots of them won't say anything. And also, you have your request and you look at the name and it's Maria something. You go out in the hallway and call Maria, and all the females stand up. We're in El Paso, okay? So that's the custom. Many people have Maria in their name in El Paso. And so you have to be very careful about making sure you have the correct patient, okay? So how are you going to do that? Ask them specifically, are you Maria? What are they going to say? Yes. Okay, so you are going to check their wrist badge that has their name on there, their ID badge. Okay, not a badge, but the wristlet, okay? Okay. All right, so we're talking about positioning on the lower extremities, okay? As this says, a foot routine. Whatever routine you do is not what these guys say. It's whatever the protocol for the hospital or the clinic that you're working at, okay? They will decide what the routine is, okay? For most places, it's going to be AP, a medial oblique, and a medial lateral. Okay, that's most places, but they may add stuff to it. Okay, but most places it's this. So again, you have to go according to the protocol for the place you're at. Okay, and then they have a special one. This wouldn't be routine, but this would be by special request that you would have weight bearing. Weight bearing means that the only way you're going to put weight on it is to stand, okay, is that you're taking standing images of the foot, of the ankle, of the knee, okay, because that way you're looking at, if the weight is on those joints, you're looking at the stressed areas when the person is standing, because it will look different upright than it does when there's no weight on it, okay? Now, the other thing, and I have an experience with this, is I don't remember whether it was a foot, ankle, or a knee. I'm thinking a knee, but I remember the tech showing me how to stand, but all my weight was on my good leg, not the one they were x-raying. And I'm thinking, you know, that doesn't make sense. You're an idiot. As I didn't say that, but that's what I'm thinking, okay? Because if you're looking for how weight affects a joint, you have to be x-raying that particular joint, right? But no, they wanted me to put my weight on my good leg, and on the leg that they were x-raying, it didn't need to have any weight on it. Well, that defies the purpose of doing something weight bearing. Okay, so you need to make sure that there is weight on that particular part. Okay. Okay, so let me. Was this the next one? I think it is. Okay. An AP foot. Okay. Now, notice on this foot, when you're looking at it from the side here, this is an AP foot, that we have a 10-degree cephalic angle. Okay. That has two purposes. One is it opens up some of the joint spaces between some of the tarsal bones, but it also gets the leg more out of the way. Okay. Now, my problem with this is they're showing you the two different views. This is from the side, this is from the front. Okay. From the front, this is supposed to be straight up like this, the leg. Okay. So I'm going to show you a bunch of problems with these lower extremities. Okay. And that's okay, because you'll learn from the problems. Okay. You guys are going to probably tell everybody, she complains about everything. Yes, I do, because everything is wrong. Okay. And like I told the first two classes, if you're going to do it right. Okay. All right. So here we're looking at an AP foot. Okay. AP foot. Okay. Everything is on here. Nothing is cut off. You have to make sure that you don't cut anything off with the collimation, because if you do that, you go, oh, it's just a little tiny bit. That may be the part with the problem. Okay. So you need to make sure to include the entire foot. Okay. And have a good technique for it. Okay. This is an oblique foot. Here it says 30 to 40 degrees, it's 45 degrees. Okay. So you're going to do 45-degree medial rotation for a foot. Now, this is not angled 45 degrees. It should be angled a little bit more. Okay. Now, I want you to look at this thing right here. Okay. This right here is a positioning sponge. It's shaped like this. Okay. It's radiolucent. That way we can use it to support the patient at a particular angle so that they don't move, and also so they don't shake. Because if they're hurting and they can rest the foot, then they won't shake, hopefully. Okay. Now, say you did a foot on somebody that's been living off the street, and they haven't had a chance to wash for a while, and you do a foot. Okay. Now tell them what the foot looks like or how bad it smells. Okay. Then your next patient is you, and they're going to do facial bones on you, but you need a little bit of support. They're going to use this sponge. Okay. Now, can you imagine all the bacteria that came off of that foot? Now it's on your face. He's going to have nightmares now. Okay. This is done all day long in every single hospital and clinic. Very rarely do people clean the sponges unless they get barium on it, because that'll show up on the image. Or maybe they had somebody that bled all over it, or somebody that had a leaky wound and there's pus all over it. Okay, then they may wash it. But you don't think that this thing is dirty after it's been under a gazillion feet, and then you put it under somebody's face? Okay, and even if you just use it for feet, can you imagine spreading disease from one foot to the other with this? Okay. And I would bet you $1 gazillion that these don't get washed or disinfected, felt like Vanna White, or disinfected between patients. So it'll go from your foot to your face. Yes, it's gross. And this is what happens in the hospital. And who's doing it? The techs. And they know they just had somebody's foot on that. Oh, but I don't have time. I'll just this once. But most of the time, they don't even think about it. So, if you could do this in between your patients when you use these sponges, and use these sponges all day long, okay? Because they're aids in positioning. You use them, okay? All right. Let's go to the next one. Okay. This is an oblique foot, okay? Now, the thing about this foot is that it's not oblique enough. Matter of fact, this was the one I said they didn't know what they were doing. It's not a straight AP foot, and it's not an oblique foot. They think because they oblique the leg that this goes with it. Not necessarily. This may be off of the image receptor just a little bit on this side, but that may be all. Okay, so this is not a true oblique foot. It's supposed to be oblique 45 degrees. It is not. They oblique the leg 45 degrees. But that's not what we're doing. We're doing a foot. Okay, so part of the problems with all of these is poor positioning. Okay, so here's a lateral. Okay, this is a lateral foot. We typically do a medial lateral. This is the medial lateral. In the medial side, out the lateral side. But we don't always say medial lateral because this is the one that we do 99% of the time. So we just say lateral. But we know what we mean because we do it all day. Okay, so this is a medial lateral foot. The positioning is fine. Okay, the positioning is fine. And you want to make sure that this is perpendicular to the image receptor. And it is. Okay, so it's typically the heads of the metatarsals that you want to make sure are perpendicular to the image receptor. These aren't going to be, because here is metatarsal 1, metatarsal 5 is right here, and it's like this. You'll see this one, then the next one, the next one, the next. So they're separated. You can't make these perfectly superimposed. These you can, but not this, because you've got an angle on your arch, a transverse angle on your arch. Okay, so this foot is fine. This is pretty much 90 degrees. This is fine. Okay, so pretty much with the foot and the leg, for most of these things, it needs, if this is the foot and this is the leg, it needs to be 90 degrees. Okay, even when we're doing angles, you want to make sure this is, or obliques, we want to make sure this is 90 degrees. Okay. Okay, so here's a foot. Okay, this is the ball of the foot right here. Okay, that would be the metacarpal phalangeal joint, and you can see the little sesamoids right there. Okay, so these are all superimposed. These are not, okay, because they can't be. Now, again, this should have been 90 degrees, okay? Now, on this particular one, does it affect the image that much? No, and it'll be accepted like this, but it's still not perfect. I mean, if you're not going to do it perfectly, why bother doing it? Okay, well, okay, I was off a little bit here, but it's off a little bit here and off a little bit here. And all those off a little bits make a really bad picture. Okay, so if you're going to do it right. Okay, all right, now let's talk about the ball of the foot. If you were to jump off just a stair, 7-8 inches or however long that distance is, you jump off a stair, what part of your foot are you going to land on? What if you used to stand up and jump? What part of your foot are you going to land on? I know you guys have jumped. Yes, the bottom. What part of the bottom of the foot? No. The balls of your feet. That's right. Okay, so you're gonna land on the balls of your feet, and that's kind of cool because it gives you a little bit of spring action there. Okay, so you don't hurt yourself as much. If you were to land flat-footed, it would jar your entire body all the way up to your head and neck. It will. Have you guys ever done that? Yeah. Okay, so you don't land flat-footed, you land on the ball of your feet because it gives you a springy action. Okay. What was my whole point here? Darn it. Oh, okay. So this takes a lot of weight. Okay, a lot of pressurized weight on the ball of the foot. And what's also on the ball of our feet? The sesamoids. Okay, so sometimes when you land on the balls of your feet like you're supposed to, you can not only break the heads of your metatarsal, but you can also break your sesamoids. Okay, you wouldn't think so. There's little bones there that protect the tendons under there, but yeah, they're breakable. They're bones, they're breakable. Okay. Okay, so here, let's look at the one on the right. Here we see a weight-bearing bilateral feet. Okay, now bilateral means that they're doing two at once, not expose this or expose this. It's expose them both at the same time. Okay. I don't like doing both of them at once, but there are reasons why sometimes that may be the protocol. Okay. And I'll give you the example when we get to a knee. But on this one, this is just one shot. It's weight bearing. They're standing on it. You see that you have a 10-degree angle on the CR. Now, this cassette that they're on, okay, this is a digital receptor. This is a very expensive one. This is the kind we have in that particular room right there. Okay, we only have one. I'm trying to get another one, but I can't find the $60,000 to $100,000 that costs. One. And when you get in the program, when we talk about digital, you will see how they're made and why they're so expensive, but they are very expensive. But I don't know if you can tell, but this is inside another setup. See, this right here, and you see there's a little handle there, okay, like that. Okay, that is inside this like box with a handle that has like plexiglass over it. So the weight is put on this plexiglass and not on that imaging receptor. Because if you stand on the middle of that imaging receptor, you will just break something that costs $60,000 to $100,000. Okay. So I just wanted you to take no, oh gosh, just a minute. Okay, let's see if I can do this again. So I just wanted you to take notice of this thing that it's in. Okay, now let's look at this one over here. This is also a weight bearing, but it's a lateral foot. But notice you can only do one at a time. Unless you're a ballerina, you can't do that. Okay, so we do one at a time, and that's better. But the cool, and it's a cross table because you see the light going horizontally here, okay? But the thing about this is you get perfect laterals. You get perfect laterals because the patient is standing perfectly, and so you'll get perfect laterals, okay? If you are doing them on the table, they're not always perfect laterals. These are always perfect laterals, okay? But on weight, on weight bearing, you'll do this one, then you'll turn around and then do the other side. No, they'll turn around and do the other side. You won't turn around and do the other side. They'll turn around and you do the other side, okay? All right. Now, on this one was done in the same shot, okay? It says to make sure that the phalanges are not rotated. Okay, these are the phalanges. Let's look at those phalanges. Okay. Okay, this one's really kind of weird. Okay. Okay. Are those phalanges not rotated? Yeah, they are. Okay. Is there anything you can do about it? No, because look, see these feet? Look at that. Put that inside that perfect pointy toe shoe they just bought. That's why their foot looks like that. Because if you wear it enough, your foot will start to conform to that shape. Because a real foot, 4, 5, okay. A real foot, a real shoe would be more like, well, I got carried away there, but it would be more like that, okay? And not force it to go to the shape of the shoe. The shoe should be the shape of your foot, not the other way around, okay? So, well, that looked wicked, didn't it? Let me get rid of this, just a second. Okay. Okay, so here we're looking at the entire foot. This is not weight bearing because if you can see, there's going to be tissue down here, and then it's going up like this. So unless he's trying to stand on his tippy toes, this is not weight bearing. Okay. Okay. This is for sesamoid bones. This is to get tangential views of the sesamoids. Let's start with this one. How do you think this patient is positioned? To do that, they probably have to be on their knees, okay? So a lot of patients can't get on their knees. I can't, okay? Only because I have bad knees. So the idea of this, I said, is tangential. Remember what tangential meant? Do you guys remember? To skim apart. Do you remember that? To skim apart. So let me get my trusty pen. Okay, so the whole idea of this is to get the toes out of the way and to make sure that this heel is out of the way. And then you can shoot straight down right through those sesamoids, and it will just pick it off. So the image, you'll have just the sesamoids. Okay, that's what's called a tangential. But this particular way to get it is difficult on the patient. Okay, now here's one where the patient is sitting there, and most patients, you don't even have to do all this. Okay, so most patients can do this. I would probably bend that back a little bit more, but oh, I guess not. So you have this so that this is all by itself. This is not in the way, and this is not in the way. So when you shoot straight down, it's going to project it right there. Okay, so it projects the sesamoids free of superimposition of anything. But the cool thing is that this one is easy for the patient. And if they can't move their toes back on their own volition, you can give them some kind of a rope or a string to pull the toes back. Okay, you're not going to be holding it, they are. Okay, so both of these are tangential sesamoids. Again, this one is easier on the patient. Okay, and this is what it would look like. Look at that. And if there's something wrong with them, you would see it because it's not being superimposed by the metatarsals. Okay. I like looking at those little bones there. That's so cute. Okay. Now this is an oscalcis or a calcaneus, same thing. Okay. Now this thing, when it's positioned in here, is kind of positioned like this. Okay. And this is the calcaneus right there. Okay. So you can see that it's kind of at an angle here. Okay. And this is almost 90 degrees to that. And then it's going to project it right there to the center. Okay. And this would be the center of the cassette. So you might have this a little bit lower, okay, because it's going to project it higher. And even though you're trying to get it so that it's perpendicular, you're still going to have some distortion there. Okay, so it will probably look a bit elongated on the image, and that's okay. That's okay. Just spread it out more. Okay. Is this the same one? Well, this is what it's going to look like. This is the calcaneus here. Okay. So here's the calcaneal tuberosity, and this is the sustentaculum tali. And we mentioned that last time. Okay, that would be this area right here. And that might be one of the reasons why you would do this. Okay. A lot of people have painful calcaneus. And lots of times they have, and which you'll see this on the lateral, they have bone spurs. Lots of people have bone spurs. So if we were looking at, just a second, let me look at the lateral here. Okay. They might have, lots of times they're going in this direction. Okay. But those are bone spurs. Sometimes they're more spiky. They're like spikes. Those are stupid spikes, but they're literally spiky. Okay. So that when they walk, if they're inflamed, then when they walk, it hurts. Okay, now they're not always inflamed and it doesn't always hurt, but people like this might be wearing something, some kind of an orthotic in their shoe that provides cushioning so that it doesn't hurt or doesn't become inflamed. Okay, and lots of times you can have surgery to shave these off, but they grow back. Okay, so let's see, did I miss anything here? Okay, so this is what and you can see that it's kind of elongated a little bit here, which is fine. Okay. This is a lateral. They got I'm always complaining they don't do 90 degrees, and this guy got more of an acute angle here. Okay. But what we're looking for here is this bone right here. Okay. I wouldn't be centering there. I would be centering right here. Okay, so this is off-centered. So this is what it's supposed to look like. Okay, so this looks good. The other one didn't. Okay, but this looks good. The positioning didn't look good on that. Okay. Any questions so far, guys at home? No, do you guys have any questions? Okay. Okay. Now for the ankle. ¿Cómo se dice ankle en español? Say it again. Tobillo. T-O-B-I. Tobillo. Okay. All right. So now we're going to be talking about los tobillos. Okay. All right. The routines are typically AP a 45-degree medial oblique, meaning you're going towards the medial, and a medial lateral. Okay, so that's typically this one, and this one. But again, it changes with whatever protocol you have at whatever hospital you're at. Okay, so let's start with the AP. Okay, so with an AP, this and this need to be 90, that's a little bit off, need to be 90 degrees. And it's not that I'm being so finicky. Okay, I am being finicky, but you're supposed to. You're supposed to. That would be like going to a dentist and go, I got the wrong tooth. It's okay. I'll get it right on the next one. No, it's got to be done right, right? If you're the patient, you want it to be done right. And it's the same thing here. It's got to be done right. So we want this at 90 degrees. And there's a reason for it. Not because I like to complain. There's a reason for it. Because when you have this at 90 degrees, it moves the talus down so that you can see the space between the distal tibia and the talus. That space will open. If the foot is like this, that talus moves up into that ankle joint, and then you can't see it open. Okay, so there's a reason for all my complaining. Okay, and a reason why you should do it right. Okay, now here is an AP ankle. Okay, and I can tell you right now through two different things that this ankle, this tobillo, is not positioned correctly. Okay, number one, I don't see that space here. And you should. If this was 90 degrees, and it's not, because look, I can see the foot going out over here. Look, there's the big toe. Okay, if this was positioned correctly, everything would be right here and white. You wouldn't see any of this. Okay, and then you see the space right here. Now, as far as it being AP, it is AP. Okay, you're going to see a little bit of overlap here, and you're supposed to. Okay, so this is going to go like this, and then this is going to go like that. So you see some overlap there, right? Some superimposition. That's normal. Okay, now remember, this is the tib fib joint. Okay, the tib fib joint is, the distal tib fib joint is not open on an AP ankle. It's not supposed to be. Okay, it's supposed to look like this, but the foot needs to be up 90 degrees. Okay. Okay, this is an ankle mortise. Now, the mortise is just, whereas this is, okay, you see it like this, correct? Okay, when you look at it like this is an AP ankle, or this is the foot for an AP ankle, okay? This is the foot for an ankle mortise. Barely, right? Just barely. That's all it takes to open this up. That's all it takes. Okay. So on this one, this one is probably okay, but they got carried away with the foot, because you know you can do this to the foot, so it's twisted a little bit. Okay. All right. So let's look at. Okay. Here is an ankle mortise. Remember, the ankle mortise, we're supposed to see this space, and this space. Do we see all three? No, we don't. What are we missing? Can you see it? You remember the tibial plafond right there? That's the tibial plafond. Okay. If this foot was 90 degrees instead of just flopping, okay, it's literally just flopping. okay? This is really, really poor positioning. So this thing, remember this one? This is the one that had the break right here. Okay, we shouldn't have been able to see that. All of this stuff should be white right here, just white, nothing else. Okay, so on a Mortise, we should see this space all black, and this space. Now, because we have the right angle here, we see these two very beautiful, both malleoli beautifully. Okay, but we don't see this space. And this is the ankle joint. That's important. Does that make sense? So if this was 90 degrees up like this, okay, we would be able to see, this space right here. Okay? This is why what is that phrase? God is in the details. Okay. There are little details, and once you get used to it, you don't have to think about it. Okay, but initially you need to learn it, or you're just going to flop it there and x-ray it and think you've got a good shot, and you don't. Okay. Okay. Okay, here is a medial oblique ankle. Okay, now this is not quite 45 degrees. Okay, so this needs to be obliqued a little bit more. And what else? And this need to be 90 degrees, right? Always like this, okay, between the foot and the leg, okay? So this right here has to be 90 degrees, okay? So the idea of this is to separate this and this right there so that you don't, so it opens that up. That's the distal tib fib, okay? So let's look. Okay, now we do not have the distal tib fib open right here. We have the lateral malleolus, but we don't have the distal tib fib, and you're not supposed to, okay? Not on an oblique ankle. I mean, not on a Mortise, okay? So yes, we separated this, but we didn't separate this because you can't until you do that medial oblique. Now that medial oblique, see how it's separated right there? Okay. What's wrong with this leg, with this ankle? That darn foot isn't 90 degrees. And on top of that, okay, so how they did it was they obliqued it, and it's just laying there, and it's twisted, the foot. You know how sometimes if you point your foot, you can kind of turn it and twist it. Okay, so this isn't positioned at all. It's not positioned at all. Okay, we were able to open up this, but that's the only good thing about this. Okay, this is all twisted here. Okay, and this should be at a 45 degree angle, and it's not. This foot is just hanging. Okay. All right. Okay, now I told you that a medial lateral foot is what's most common. Pretty much everybody has a medial lateral, ankle, a medial lateral ankle versus a lateral medial ankle. Okay. This medial lateral ankle, because that's what we always do 99.9% of the time, we just say lateral ankle. More proper, more correct to say medial lateral, but that's not how we talk. We just say a lateral ankle, okay? Because this is what we do. Now, once in a while, for whatever reason, you may have to do a lateral medial ankle. What's wrong with that foot? Again, it's just slapped on there, right? It should be like this. What is so hard about doing it right? I don't get it. And it may not be that it's not so hard. It's they don't know any better. Where did they go to school? Not here. Okay, because you're going to learn the right way. Okay. Maybe that's why everybody's doing it wrong, because they're all listening to the book. But anyway, okay, so it's got to be like this. Okay. Now, this one, if you're laying on the table, this one is really hard to do. Okay. Most people can't do this because when you do this, you need to make sure that your whole leg is on the table. Okay. Is that you can almost see this leg is coming off of it. Okay. You can almost see by the amount of shadow you have here. Okay. That because it's almost, for a lot of people, it's almost impossible to get that done unless you raise the with a sponge and then put the cassette on top of that. Okay. But even so, it's very hard for people to go all the way in. They can go this way because that's how your legs flop naturally. Okay. But not that way. Now I can do it like this, but notice that my foot and my leg are not on the same plane. Okay. We need to make sure that they're in the same plane, and they're not going to be. Okay. So it's really hard to do this, a lateral medial this way. You could do it. With patients laying on the table like this. Okay. You put a cassette right here and the CR right here. This is a lateral medial ankle. Well, that was easy. And the patient didn't have to do anything, and you didn't have to make them hurt. Okay. And you'll probably get a perfect ankle. Okay. So if it has to be done this way, it's probably best to do it cross table. Okay. And this is the patient's leg. This is the patient's foot. Cassette right here, CR going this way. Okay. All right. So, but this is what we almost always do. Okay. Okay. What is this supposed to be? A lateral calcaneus? Oh, it's a lateral ankle. Okay. So this is a lateral ankle. Now, you know that it's positioned properly because, okay, look, I am following the distal fibula. Okay, now let's look at the distal tibia. You see how it's superimposed? That's how it's supposed to be. So to know that you have a good ankle, lateral ankle, and it's not rotated, the distal fibula needs to be on the posterior half of the distal tibia. Okay, the distal fibula has to be on the posterior half of the distal tibia. Okay, so this is good positioning here. And look, we've got 90 degrees. That wasn't so hard, right? So again, how they show it and how they do it are like two different things. Okay, and this looks awfully short. A short calcaneus, typically those, they go way out like that. And when you look at it, you think about it, oh my gosh, you know, he's got a freaky looking foot. But when you think about it, okay, it kind of goes like this on the foot with the tissue. Okay. Okay, this is an AP leg. And AP leg, if you can fit it on a 14 by 17 lengthwise, you need to include both joints. Both joints don't fit. This person's leg does not fit. Many people's legs do not fit, but you could do it this way, catty corner. Okay. You could do it catty corner. catty corner and include both joints. But, okay, you know, if you're using digital and you're using that image receptor and you're getting it out of the table and putting it on top and then turning it catty corner, that works. But we're not going to allow you to touch that unless you fork over as collateral $100,000. Okay, because one drop from here to here will ring it. That's how sensitive it is. So most of the time, you're not going to be taking these out of the table. Okay, so that's probably more than you'll make in a year. They're not going to chance it. Okay, so you're going to go ahead and do this when this is in the table in the bucky. Do you remember the bucky? We talked about that at the very beginning. Okay, so in the bucky, you have a tray you can pull out and you can put this in there. Okay, except they're almost like now, because we don't want you taking those out, like permanent in there. Okay, and you don't have to adjust the bucky or the image receptor, touch it at all. All you do is you position the patient and then move the patient up, move the table that the patient is on over where you want it. Okay, so you don't have to mess with this. But you can't put one of these in the bucky catty corner. And if I'm telling you that most people, or at least 50% of people, don't fit this way to include both joints when you do it this way. Okay, so what do we do? What we do is, okay, include the joint that is closest to the trauma. Okay, so if the injury or owie is like right here, then you're going to put this right here to make sure you include the ankle. Okay, so are you going to cut off the knee? Yes, but that's okay. Okay, if you were hurt right here, then you would make sure to include the knee. Are you going to cut off the ankle? Yes, but it doesn't matter. So when you're doing an AP leg and you're doing it lengthwise on a regular 14x17, you need to include what's your problem? You need to include the joint that is closest to the trauma. Okay, what if it's dead center? You decide. You decide. Okay, or you can do both. Okay, do one with the knee and one with the ankle. Okay. Okay. Do I have two of those? Is that the same thing? It is, isn't it? Okay, so this would be a leg. They've included both joints on there. Okay, but both joints are on this one. Okay, but remember I said they don't always fit. So just make sure you include the one that's closest to the injury site. Okay. Okay, now here is a lateral leg. Okay, now notice the positioning of the leg, not of interest. Okay, they tried to make her comfortable. They put it on a sponge. Okay, and it looks like it's out of the way because you can tell by the shadows. Okay, looks like it's out of the way. Another way to have done this would be to take this leg right here, okay, and bring it up like that. Or take this leg right here, this is the femur, this is the lower leg, and then the foot on the table, like that. So any way that it's going to be the most comfortable for the patient, as long as it's not in the image. Okay, because you don't want to have a foot you know, in your collimated area, okay? And notice that they're doing this one catty corner, okay? Okay, here is a lateral leg. It's a child's, okay? They probably should have, since they did a catty corner, I don't know if they just went ahead and cropped it out, but they should have had both, especially since it's a kid, it would have fit, okay? Now, I know it's a kid because look at this. What is that? What is that? Fist plate, yes, epiphyseal plate, okay? So we know this is a child. And I just noticed this in the second class, and I'd used this picture before, didn't even see it, but you see this right here? What do you think? And right there, that's a fracture. Okay, you see it? So when this comes apart, this is going to be sharp and this is going to be sharp. Very dangerous. Okay, because if that slides right off, then both of these sharpnesses are going to cut things. Okay, does that make sense? Like it's together now, but when it slides off, the ends, the sharp ends are going to cut stuff. Okay. And bones can be very sharp, like razors. Okay. Okay. Now, here is 2 knees, but 1 shot. So we would call this bilateral knees with 1 shot. Okay. The joints are centered. Now, I don't know why they did this, but if you were looking for detail in each of the knees, this would be poor quality. Okay. The whole idea of doing joints is to open up the joint space. Okay. So when we do a knee, when we do an AP knee, okay, we center the joint. Where do we center? A 1/2 inch below the apex of the patella. Yes. Okay. So, and the whole idea of that is to get the central ray right in the middle of the joint space. Okay. Now we have the central ray right here. Okay. But let's talk about the beam. I know we've talked about this before, but I'm going to continue to talk about it. Here's the beam, the X-ray beam. Okay. So the center part is perpendicular to the image receptor. As we go out, those rays are divergent. Now, it's not just this way, it's all over. Okay? So the beam is divergent all over, but the center part is straight. So if you center on the joint, you will open up the joint. If you put the divergent rays somewhere else, then it's going to distort whatever it is those divergent rays are going through. Anytime you do this, you're going to distort the image. Okay? So this is the part that will give us a very good image, not this. Okay? So here's where the central ray is. Oh, look at the detail on the nothing. Okay? So we have the central ray right here. And all around here, on the rest of it, we have divergent rays. Remember, because this is a 1-shot thing, right? Got both of them on 1 shot. So that this, is that open? Let me show you an open one. Look at that. See the difference? Look at all this empty space here, okay? You see the empty space there? Not so much, because the central ray is not going through the center of the knee. It's going through the center of the image plate, but not of the knee. Okay, because once you get out towards the side, you start getting divergent rays. Okay, all right. Now there may have been a reason for them to do this. Okay, but you're supposed to do them one at a time. unless they say do it bilateral on one image. Okay? For the simple reason that you will not get a good knee. These are not good knees in terms of a good AP knee, but there may have been another reason for this. Okay, maybe they're just doing comparison studies. Okay, maybe they're looking to see if there's a difference in the length, like one knee joint is here and one is right here. So there are different reasons for doing this, because if you did them separate, you would just think, oh, they didn't center on one the same. But if you do them on the same one, that would be more specific. Okay, so there's all kinds of reasons for doing them together, but in terms of perfection on one knee, you're not going to get it. Okay, on an AP knee. Okay, you have to do them separate. Okay. Okay. Where are we? Okay, so this is obviously a child. Did I forget something? Okay, this is just a plain AP knee. Okay, because you don't see the field over this. Okay. Okay, now here you see a space. Now this is rotated a little bit. Okay, and you can see it because the tibial spine. See the tibial spine right here? It looks a little bit crooked. Okay, it's not too bad. This is very passable. Okay, but here you see the epiphyseal plates, but we also see something in the joint space that's calcified. You see that? Okay, maybe that's why they're doing that. I don't know. Okay, and you can see right here also the epiphyseal plates. Okay, so this isn't a bad knee. Okay, supposed to have 45-degree rotation. We don't. Okay, it's not enough. Again, it's kind of hard. It's kind of hard to get your patient to rotate the knees inward like that. Okay. Now, this is an internal rotation. Typically, if you only do one oblique, it will be internal. Okay. This is an external rotation. Now, it may be the protocol to do internal and external. I worked at a place once where we had to do internal and external. Okay. But if there's only one oblique, it's a medial. Okay, versus an external or lateral rotation. Okay. But if the protocol is all four, do a medial and, an AP, a medial and a lateral oblique and a lateral. Okay, so that depends on what the protocol for your place is. But this is a lateral oblique. Okay. Okay, so here you see a medial oblique. With the medial oblique, I'm not going to draw on it because then you'll miss it. But do you see this right here? That is the distal tib fib, the proximal tib fib joint right there. Okay, and you see that. That's with the medial oblique. With the lateral oblique, okay, this is the fibula right here. And this is the tibia, okay? So you can see it's totally superimposed on the tibia, on the external oblique, okay? Medial oblique, you can open the proximal tib fib, and on the lateral oblique, they're totally superimposed, okay? Okay, again, you see the kind of the same positioning as before, where you've got this leg out of the way. Again, you could put it behind, still behind like that, or you could put it in front like that. Okay, come on. This being the femur, this the leg, this the foot. Femur, leg, foot. Okay. Or you could have it behind like this. Now, when you put it in the front out of the way, a problem comes that you over-rotate it. So you no longer have a lateral. It's a rotated lateral, okay? Now, doing it like this, it allows you to get a nice lateral. But what the heck? How did they screw this up? It's not lateral. It's over rotated, okay? This kneecap should be right here. But you see it's kind of facing down, isn't it? Okay, so that's going to close that patellar femoral joint space that you should see on a good lateral. Okay, do you remember we saw a picture of that before? I said that this is a perfect positioning, the technique's off, but perfect positioning. Okay, you should be able to see that space between the patella and the femur. Okay, now you're not going to on this one. This patella is just about leaning on the table here. Okay. Also notice that you would angle 5 to 7 degrees cephalic on the lateral here. Okay. Okay, so here's a perfectly positioned lateral knee. Okay, so you would have this like this and this 45 degrees. And it's so that's good. And this is good. Look at that. That's beautiful. The reason why I'm praising it is because a lot of people do crappy lateral knees. You should be able to see this whole joint space here. Okay. So this is a nice lateral. Okay. And you see the condyles perfectly superimposed. Any day now. There we go. Okay. Here's a funny looking one. All right. Now, this is called a Holmblad. Okay. Remember when there is a person's name? I mean, couldn't they think of something any funnier? This is Holmblad, and then they call it a method. Okay. So if you look at how she's positioned, this is the table. She's leaning on the table. You can see that. It's your elbow on the table. Okay. This is a chair. It's kind of hard to tell, but that's a chair. And whoops. And right under it is a sponge to help keep this parallel to the lower leg. Okay, otherwise it would tilt down. Okay, but there's a sponge right there. And this is like this. Okay, and this is angled forward. That's the femur right there. Okay, so she's standing on this leg over here. You don't see the whole thing, but there it is. Okay. So she's standing on that leg. There's no weight on this other than the fact that she's touching it. Okay. And so she's leaning forward. The whole idea of this is, remember let me put this spotlight on me just a minute. Okay. The whole idea of this, remember, this is your femur, right? This is your distal femur. Do you remember this? Take a look at it. This is the back of it. Okay, right here. Okay, this is called the intercondylar fossa or the intercondylar notch. Okay, you remember this? We even saw something like this, how they drew it. Okay, now what you're looking at right here on the leg of interest right here, okay, is that she's just like this, okay? And what we're doing is that this is the beam and it's coming down and is shooting through the lower part of her distal femur or the distal femur, okay? So we're shooting straight through here, and the image we get, we're going to get an image of this, okay? It's going to go right through that. And that's what we're going to see. So she can't be back like this. Okay, it's got to be, and we're just going to skim this. Okay, now her legs are kind of skinny, so it's pretty much okay. It's pretty much okay with her, but sometimes you got heavy duty thighs here, and you'll go through the thighs, but you'll have to increase the technique. Okay, you don't want to put too much of an angle or you'll distort it too much. Okay, so that's called a Holmblad. Now, there's another way to do the Holmblad. Let me show you this one right here. Okay, now that one that one, okay, it's like this. She's leaning forward and you shoot right through here. And that's how you get the notch. Okay. So this one, however, would be very hard to do for most people. Okay. Sometimes you tilt them forward and they fall forward. Okay. If they can even get on their knees. Okay. Because if their knees are hurting, they're not going to get on them. Okay. So that's another way to do the other one. This is the way I always did it because I didn't know this 1,000 years ago. I didn't know that existed. And wow, that is like perfect. It's perfect as long as they can stand. Okay. You know, and then they can also help support themselves with their arm right there on the table. Okay. Unless the table moves and they fall forward and you kill them, but you don't want to do that. Okay, now this one is called the Camp Coventry. This is also a way to get the intercondylar notch. Okay, so on this one, where am I? Just a second. Okay, so on this one, they're laying like this. The patient's laying like this. Okay, so that's fitting right over her femur. Okay, and you're going to shoot at an angle, perfect angle to get that intercondylar notch. Okay. And what do you see right here? Helping the leg stay up, because if you don't have support on this, when you go to take the picture, it's not going to be in this angle. I promise you. It'll probably be like this or like that. So you have to have something to support the patient. And that's what these radiolucent sponges are for. And you can tell by this that these are very old. Can you imagine all the bacteria on them? Ugh. They have some that are covered in a kind of a plastic that you can wipe off very easily, but still people don't wipe them off. So, but anyway, okay, I do want to make a comment, okay, which I just now noticed, okay. You see how this is going down? They just shot it right off of the cassette. It's not gonna, you're not gonna have a picture of it. This center right here should have been down there, because it will project this all the way down to there. Whenever you use an angled ray, it's going to project it in that angle. Okay. Now, if you were shooting straight down, you still wouldn't be in the center. They kind of forgot about this. They forget about a lot of things. Don't worry, if it's wrong, I'll see it. Okay. This is what you'll get. Now, lots of times this will be a little bit more distorted, but that's okay. Okay. So the whole idea is to see in between here. Now, what is in there? Remember the ACL and the PCL, the anterior cruciate and the posterior cruciate? Those are the ones that help with front to back stabilization. Okay. That's what's in it. You don't see it that well. Typically, because it's soft tissue, typically when you're looking for something in there, now they're going to do an MRI for the soft tissue part. Okay, so they're still doing this, but I don't think it's going to be that much longer. Okay, now, but I do see something funny going on here. You see this? I don't know if it's funny or not, but it looks a little weird. See, there's some densities right there, circular densities. You got a whole bunch of little ones right there, but those would be concerning. What is What is this? That's the patella, right? Okay. The end. Okay, let me get you guys back on here. Okay. Do you guys at home have any questions? Do you guys at home have any questions? No? Do you guys have any questions? If it is, it'll be very basic. I'm not going to expect you to know how to position. Okay, because this isn't a positioning class. Yeah, okay. But I do want you to be able to recognize that this is a lateral, this is an oblique. Okay, this looks like a medial oblique, this looks like a lateral oblique. Okay, I'm not going to ask you to position something for me. Okay, so yeah, on the positioning part, it's going to be very basic because this isn't a positioning class. You just need to know when you see an image, kind of how it was positioned. Or if you see a position, you can kind of in your mind say, oh, I know what that's going to look like on an x-ray. Okay, so that when you see that home bled, you know you're going to see that little notch. Don't worry, I won't put the word home bled or Camp Coventry in there. Don't worry about that. Okay? Not next week. Okay? Is that close enough yet? Because she wanted to know when you were going to have the test. Not next week, because we still have 5B to do, which would be the femur and the hip. I'm thinking it can be done in one day, but I'm going to kind of leave it open. Okay? So for sure, not next week. Okay? So it might be not Tuesday, Monday or Wednesday of the following week, but I don't know yet. Okay? Because I'm kind of playing it by ear. I don't want to go too fast. I don't want to go too slow for you guys. Okay? But it will not be next week, I promise. Okay? Okay. Any questions? No? Questions? No? Okay. So I'll see you guys next week. Okay? Bye.